Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to RTP Live from Chicago. As today our faculty discuss the management of soft tissue sarcoma and other connective tissue neoplasm. We're joined today by great faculty, Dr. Rashmi Chugh from the University of Michigan in Ann Arbor, Michigan, and Dr. Mrinal Gounder from the Memorial Sloan Kettering Cancer Center in New York. We will be talking about the use of unapproved agents and regimens today, so please consult the package insert for various products for approved indications. Here's where we're heading today. As all of you know, our primary target audience in general and continuing medical education is the community-based general medical oncologist. The same docs are seeing breast cancer, colon cancer, CLL, myeloma. What an exciting time to be a general medical oncologist, but also very challenging. Our work has always been very modeled after rounds, and we try to get into questions for investigators. And for this particular meeting, we actually did a survey over the last couple of weeks of 50 general medical oncologists, and I picked out some of the questions they have and cases they have to discuss here today with the faculty. So we're just to kind of get started, I want to just comment, first of all, on the prevalence of this in the general medical oncology community. Of course, almost all general oncologists have patients with soft tissue sarcomas. Interestingly, about half of these 50 docs had patients with desmoid tumors in their practice, and far fewer, only 8 out of the 50 had GCT. And of course, many of these are very uncommon. And before we get started, I just want to reflect back on many comments, Rashmi, that we heard from oncologists about the challenge of taking care of these patients. As you see here, one issue being that, of course, not everyone is located near a large tertiary institution. So the issue of trying to network with investigators is always a challenge. And this is not a common part of oncology practice. I've been taking the every 3-month oncology boards. I don't see too many questions on soft tissue sarcomas. Mrinal, you did a symposium. I want to ask you about, you were part of a symposium at this ASCO meeting on what it's called, I didn't even know this term exists, ultra rare soft tissue sarcomas, which I think gives you an idea of the challenge that the oncologists face. So Rashmi, any sort of general comments about trying to network with docs in the community and the challenge of these patients receiving up-to-date therapy when it's such a small part of practice?
I can definitely relate. It's even hard for us to keep up in the community. There's so many evolving treatments, and there's so many evolving changes in the pathology world. So really trying to, make sure we have the right diagnosis is key. And then there's a lot of nuances to dealing with different histologies. So can definitely relate, and definitely always kind of recommend touching base with a sarcoma medical oncologist when there's any questions.
So, Mrinal, I've always loved talking to sarcoma people. I call you all the Talmudic school of oncology. There's so much data that you're the only ones I think who really understand it. We go to you for that. I wonder about the culture of who ends up in this field as well. You have your big sarcoma meeting coming up in Boca Raton this fall. I'm not going to say you all are nerds, but you know a lot of stuff that we don't know about. I always think to myself, what kind of fellow would want to go into sarcomas? What kind of a personality? Any comment, again, on the challenge of this in oncology practice? And can you talk a little bit about what ultra-rare tumors are?
Yeah, absolutely. So most of sarcomas are rare tumors. Ultra-rares are ones that are at 1 per million or less. And I would say there's probably about 25 to 30 different sarcomas that fall into that category. As to the type of personality that gets into this space, I think it's people who kind of like the wild, wild west of oncology, where a lot of things there is no, there are not a lot of, clear-cut guidelines on exactly what to do. There's very little algorithms. to help. So I think if you like that kind of a space, then this is a good place to be.
I've been kind of disappointed that telemedicine didn't, infiltrate into clinical practice the way it did for us. I mean, it totally changed the way we do CME when the pandemic came about and telemedicine came in. Do you deal with a lot of, second opinions virtually, Mrinal? We have the issue of, state lines and things like that. And are there any sort of centralized ways to get second opinions virtually?
Yeah, so as you know, during COVID, we were doing a lot of telemedicine across most states. Everything changed. Personally for myself, I actually have like a limited practice in Florida. So, I see a good number of my patients, many of them, who live in New York, they travel to Florida during the winter. So I continue seeing them in Florida, but I tell them, like, look, I can't take care of you out there unless you have a local medical oncologist who can do the foot on the ground, the boots on the ground sort of an approach. So yeah, we do that. Even for New York, there are patients who are in upstate New York for whom it could be an 8-hour drive coming into Manhattan. So when inappropriate, I think it's wonderful.
Well, I look forward to the day when there's more of this available. But let's talk about some of the data we have. Rashmi, you're going to get into the issue of novel agents and strategies. There's so much going on in this field. There's no way we could cover it in an hour. We picked out some of the more interesting areas and where things are developing. So, Rashmi, take it away.
Wonderful. Thank you for the invitation to be here. I have a lot of things I wanted to cover today. I'm going to start with just kind of a general introduction and was asked to touch on the historical approach to management of soft tissue sarcomas, and then we're going to get into some of the novel therapies. So as many of y'all realize, sarcomas are incredibly heterogeneous. They're cancers of the connective tissue, less than 1% of all adult cancers, and really can occur in any place, in any form, at any age in the body. So how do we make sense of this? So we like to kind of categorize these tumors into some broad categories just so we can kind of get a handle on them a little bit. So we typically divide them into bone sarcomas or soft tissue sarcomas. Soft tissue sarcomas are definitely much more common, 80% of sarcomas. And some broad groups of soft tissue sarcomas include GIST and rhabdomyosarcoma, which have very specific algorithms. So we're really going to be focusing on the aggressive, what we call the chemosensitive histologies, which are the more common ones that are dealt with in practice. When we kind of approach these sarcomas, there's, over 100 different histologies. So typically, one way to approach them has been to lump them into a major group of treating cytotoxic with cytotoxic therapies. There's definitely some basis for this. These tumors all have a mesenchymal origin and often respond to the same cytotoxics. But the other strategy we're going to talk about is kind of splitting all of these histologies and thinking of them separately because we've learned a lot about the behavior and sensitivity to treatments of each one. So kind of getting back to historically how we've lumped therapies for aggressive soft tissue sarcoma, we've typically used cytotoxic. And I thought this would be important to show as we see some of the newer agents that really our backbone agents, our best agents are doxorubicin and ifosfamide. And you could see here, compared to a lot of the more common diseases, our response rates are really quite sad. Still just kind of on the range of 10 to 15% response rates with our best drugs with doxorubicin and ifosfamide. And then lesser agents of dacarbazine, gemcitabine, pazopanib, and then certainly use combinations. Despite all this, doxorubicin is still our first-line agent, and I'm going to go through just two really quick historical studies that kind of cement that. So this dates back an old study by the ERTC looking at doxorubicin and adding ifosfamide to it, so comparing doxorubicin versus doxorubicin ifosfamide in the metastatic setting. And the bottom line, what we saw here is that We did have some improvement in PFS and response rate, but really not a significant improvement in overall survival, although there was it was a small study with a trend. So based on this, we really still have doxorubicin as our standard therapy, and we reserve doxorubicin combinations for patients who may benefit from a tumor response and can tolerate the toxicities of the agent. And then a group from the UK performed another study bringing our second-line treatment that we typically use of gemcitabine docetaxel, trying to see if that could be superior to our standard first-line agent of doxorubicin. And this was the Getty study, which randomized patients to doxorubicin versus gemcitabine and docetaxel. And here also we didn't see a significant difference in the outcomes of PFS or responses, but really looking at some global scores, global health scores, and some convenience issues with more infusion trips and treatment delays, we kind of realized that gemcitabine docetaxel was not superior in the first line. And so doxorubicin really remains our standard of care for most aggressive histologies. And over the years in the sarcoma community, we've tried to add a lot of other agents and really haven't found much in most histologies. So then we're looking at really this unlimited spectrum of disease and really limited effective systemic agents. So what do? We honestly rely very heavily on local therapies, even for metastatic disease in the advanced soft tissue sarcoma stage. So surgery, radiation, interventional-based therapies are very commonplace. But in general, most histologies, we still start with systemic therapy with doxorubicin. And as you can see, new strategies are desperately needed. And that's kind of when we rely on our new biology information. We know that approximately a third of sarcomas have really known specific molecular drivers or aberrations. I only put a few on the board here right now. Just as kind of the prototype gastrointestinal stromal tumors we know are driven by specific molecular aberrations. PEComa we're going to talk about in a few minutes. And then we have a number of translocation-associated sarcomas that are really driven by transcription factors that are difficult to target. But based on some of this biology work, we're really learning how to focus therapies on the molecular driver and histology. So I'm going to give you one example, is in perivascular epithelioid cell tumor, also known as PEComa. So this is one of the ultra-rare soft tissue sarcomas that Mrinal mentioned. It often originates in the uterus and has some muscle and melanocytic markers. We have learned that molecular aberrations are very common in the TSC1 or TSC2 genes, and these negatively regulate mTOR signaling pathway. So essentially, we have learned that by blocking this pathway, there is some potential benefit to slowing down this disease. This disease falls on a spectrum of more benign PEComas, but we know that that malignant PEComas can be a very aggressive soft tissue sarcoma that often metastasizes. It is not sensitive to cytotoxic chemotherapy, but oral mTOR inhibitors did show some benefit. So then along came this new agent of nab-sirolimus, which essentially is albumin-bound sirolimus nanoparticles. It's a novel intravenous mTOR inhibitor that has significantly higher intratumoral drug accumulation and has better mTOR target suppression than some of the oral mTOR treatments. So the phase 2 AMPAC study was conducted using nab-sirolimus in advanced PEComa. This had a total of 31 evaluable patients, and really we had some impressive response rates with 39% long progression-free survivals in the order of 10 months. And in terms of toxicity, we saw stomatitis that was often remedied by steroid mouthwash, fatigue, and rash. So overall, a tolerable therapy that can be used for quite some time. So nab-sirolimus was FDA approved in 2021 for this ultra-rare sarcoma of malignant PEComa. Kind of a next example is another ultra-rare sarcoma called epithelioid sarcoma. So this disease has a very variable natural history, can be indolent to aggressive. when looking at kind of trying to collect our data to better understand the disease, we know it tends to affect young adults, median age of 33. And our first-line treatments are pretty poorly effective, with response rates ranging in the 15% range, and the second line 10%. We have learned a lot about the molecular biology of this disease. We know it's characterized by the loss of INI1 or SMARCB1, and that leads to aberrant EZH2 activity and an oncogenic dependence on this. So it made perfect sense for epithelioid sarcoma to be added on to a basket study of an EZH2 inhibitor of tazemetostat. So in this basket study, we were able to garnish the international sarcoma community to enroll 62 patients with this ultra-rare sarcoma, and was able to find a comparable overall response rate of 15%. But what was most impressive about this was that there were some patients that you'll see in the waterfall plot really had some deep responses, as well as some patients that were able to be maintained on treatment for quite some time. And the other piece of it was extremely well tolerated compared to our standard therapies. So with all of that information together, tazemetostat was able to receive accelerated FDA approval in 2020 for the indication of this ultra-rare sarcoma, advanced epithelioid sarcoma. Our next exciting agent on the sarcoma screen is adoptive T-cell therapy, specifically in synovial sarcoma, which is another rare aggressive soft tissue sarcoma. It's characterized by a very specific translocation, but we also know that the majority of tumors express cancer testis antigen NY-ESO-1 and MAGE-A4. And then along came amitriptyline autoleucel, or afami-cel, which is a high-affinity T-cell receptor therapy to the MAGE-A4 antigen. So essentially this TCR gene is transduced into autologous T-cells via a lentiviral vector. And it is, because of the way it's manufactured, it's restricted to patients with a specific HLA-A02 genotype. So the Spearhead-1 study was conducted using this agent in patients with advanced synovial sarcoma. Myxoid round cell liposarcoma is another sarcoma that has expression of MAGE-A4, so they were included as well. Patients had to have the HLA-A02 positivity as well as the MAGE-A4 expression. And had a complicated schema in this study where once patients were judged to be eligible, they underwent leukapheresis and manufacturing of the Spear T cells. Then patients underwent lymphodepletion and then the T cell infusion. So this was a complicated process up front, but the outcomes were really quite impressive. There were significant AEs that we might expect with T-cell therapies, including cytokine release syndrome. Most of them were low grade and 70%. But the outcomes we saw in terms of efficacy were really quite impressive. So in synovial sarcoma specifically, response rates of 39%. And the interesting thing was really that lengthy duration of response. 11.6 months was the median duration of response in the synovial sarcoma patient population. I wanted to touch on a quick case. This is a patient of mine with refractory synovial sarcoma treated with multiple lines of therapy, and then poorly tolerated the treatment, and then underwent the therapy on the Spearhead study. And essentially, we saw an ongoing partial response, a lot of work up front for this, but then the patient was off treatment and continuing to respond for months. And that this study led to approval of amitriptyline autoleucel for metastatic synovial sarcoma via accelerated approval. But unfortunately, it's only applicable for a minority of patients that have synovial sarcoma, have HLA-A2 presence, as well as MAGE-A4. Lastly, what about checkpoint inhibitors in soft tissue sarcoma? They're everywhere. Why not sarcoma? Unfortunately, there's only certain histologies that have shown a reasonable signal of benefit. Undifferentiated pleomorphic sarcoma, dedifferentiated liposarcoma, and angiosarcoma. All of these have some nice signal, but we do not have a great predictive marker. There is some work looking at specific immunophenotypes that may be predictive, but those are not easily accessible clinical studies. And there's also some positive signals in the neoadjuvant setting with radiation and undifferentiated pleomorphic sarcoma. So really the only histology where it's FDA approved is in another ultra-rare subtype called alveolar soft part sarcoma that most commonly happens in the AYA population. It's notoriously resistant to cytotoxics. A phase 2 study was completed in alveolar soft part sarcoma and showed an impressive response rate of 37%. And atezolizumab was approved in 2021 for patients with metastatic alveolar soft part sarcoma. So we've really built a repertoire of histology-specific agents in soft tissue sarcoma. We talked a lot about these that are now FDA approved, and we're really tailoring our treatments better. Kind of moving forward, there's a lot of interest in additional targets as well as combining strategies, immuno-oncology along with targeted therapies, a lot of studies that are ongoing that we heard about at ASCO, and some new antibody drug conjugates. But in summary, historically, we've been treating most aggressive histologies with doxorubicin initially, using combinations when applicable, and really prioritizing quality of life and toxicity, adding in local therapies. A lot of these recently approved agents are histology or pathology specific and are preferred in earlier lines when they're applicable. So in the future, we have a lot of interesting things still to see.
So that was great. I want to kind of get into some of the questions we got from oncologists. This is just a few of many, many comments about the expression of frustration that they can't keep up with the field, and I think this is a good way to get started in that. Mrinal, again, before we get into some of the specifics of what Rashmi just discussed, I thought this was an interesting question. What are some of the key mistakes or things that people do in the community that maybe you wouldn't do in terms of evaluation and management of these patients? And what about the issue of core biopsy?
No, these are both key issues. I think when it comes to core biopsies, you have to send it to the specialty surgeon, because if you do the biopsy in the wrong angle or you approach it incorrectly, it could end up becoming an extremely morbid surgery. So I would say if you think about sarcoma, I would say start thinking about a referral, starting with the surgeon who ultimately is going to resect the tumor and knows the approach in which it is being removed.
So we had a bunch of questions about PCOMAs that Rashmi just discussed, particularly in terms of sirolimus. Can you talk, I'm curious if you can talk a little bit more about your clinical experience with this agent, Rashmi, in terms of tolerability, and also a question here about is it being used in the neoadjuvant or resectable situation?
Yeah, great questions. The toxicity profile of nab-sirolimus is similar to other oral mTOR inhibitors, and really is quite manageable with dose adjustments. It's not uncommon to need to do dose adjustments, and also support patients for their stomatitis. But overall, it's one that we can keep patients on for a reasonably long duration. In terms of neoadjuvant therapy, typically, for most soft tissue sarcomas, if we're going to use neoadjuvant therapy, we often use radiation therapy if it's a reasonable location to consider that. Systemic therapies, unfortunately, are not 100% effective, and if a patient has borderline resectable disease, we may focus on that as a modality rather than a systemic agent, although the activity is quite impressive.
So, Mrinal, I'm curious, actually when Rashmi went through the tolerability issues, sounds a lot like what we've heard with oral mTOR inhibitors, the mucositis, et cetera. Can you give us a little more granularity, Mrinal, about your experience with this agent and the typical tolerability issues that come up?
No, it's actually really an excellent drug, and we don't see really any different in terms of tolerability compared to all the other mTOR inhibitors. But the activity here is really meaningful, and this question about should you use it in the neoadjuvant setting, I don't think I've heard that question before, but I think I think why not? I think this drug has such high response rates. It would be interesting to use it in that context, and I think on a case by case basis, it's definitely worth a conversation around it. But with all the supportive care meds that we have, I think Rashmi said, oral steroids for the stomatitis. Even the stomatitis is not so bad. But with proper supportive care, this drug has excellent quality of life.
So, Rashmi, we actually had a case. I was surprised of a patient with PCOMA, a 51-year-old man with actually a breast mass that was excised that showed a PCOMA. The doc wants to know any role for adjuvant therapy. And have you seen this presentation?
PCOMAs are unusual. I can't say that I've seen one in the breast. But, this is one of the key points about managing soft tissue sarcoma in the community. PCOMA is really a spectrum of diseases. So just based on knowing that it's a PCOMA, it's hard to know whether it's, kind of along the more benign spectrum or the more malignant. So, something that just says PCOMA, I might assume is more of a benign variety if it doesn't specifically say malignant PCOMA. But this is where we really rely on our soft tissue sarcoma pathologists to help guide us. So that's one of the key factors, I think, in managing this disease is really getting this reviewed by a sarcoma pathologist. Typically, we don't use adjuvant therapy for this. Even if it was a malignant PCOMA, we would focus on local therapies and then monitor closely. We just don't have data for that that's approved in the metastatic setting.
So, Mrinal, what about patients who progress after receiving nab-sirolimus? What's next?
There's really no clear sense of what's next after nab-sirolimus. I think it's I think sometimes we've used immunotherapy. I think there was a poster here at ASCO presented from our group showing the role of dual checkpoint blockade. So I think that's reasonable on a case-by-case basis. Also, I think we would think of using TKIs and certain other types of chemotherapies. But there's really no clear sense of what is the best drug. But just quickly going back, I think the most important thing in sarcoma is pathology. These tumors are extremely complicated, and even for experts like us sitting at major centers, it's still very complicated. There's not a week that goes by where each of us don't ask each other, have you seen this before? This is a really rare entity. How do you treat this? So we also don't have all the answers. So it's a really complicated space. So I think there is a lot of role. It's extremely important, this tumor, if you're thinking about sarcomas, to have it reviewed by a sarcoma pathologist who has deep interest and expertise and thoughtfully brings in molecular testing to make sure that diagnosis is correct, because it really is starting to now make a big impact on how the patients should be treated. Should you even treat them? Should you observe it? Or should you do cytotoxics, or should you do any one of these drugs that have been approved? So I would say pathology. It's a very complicated space.
So, Rashmi, a couple questions from the chat room. Carlos wants to know about the potential role of radiation therapy in soft tissue sarcoma. Is there a role? And Chu asked a question. I'm just going to pass on because I'm not sure what this means. Any suggestions for the treatment of TFE3 translocated PCOMAs?
Yeah, really tough questions. So, definitely there is a role for radiation therapy for soft tissue sarcomas, both in the localized setting. We often use it neoadjuvantly, preferably than adjuvantly, depending on the surgical preference. So it's very important in helping to decrease local recurrence rates. In terms of palliative is also obviously an important where we use it as well. Then in terms of the TF3 fusion, that has been a question that's been posed. I don't think that there's a great answer. I tend to use a lot of anti-angiogenic therapy with PCOMAs as well. And so there is some benefit we can see there, but not an easy answer and definitely an open question for the community.
So another question from the chat room with Carlos. Is there a role for NGS up front and workup of a patient with sarcoma, Rashmi?
Absolutely. I think that for especially patients in the metastatic space, I would recommend NGS. would be shocked at what you can find. Even histologies that you think are, we think we understand the aberrations that we would predict and that they're not actionable. We sometimes find, an ALK fusion in a patient with leiomyosarcoma that's really changes their whole management and course. So in the metastatic setting, when you start along the path of systemic therapy, I would definitely recommend NGS and in a limited basis and the localized.
Yeah, what I would add to that is it really depends on the type of platform being used. So not all NGS platforms are made equal. So I think it's important that whichever platform is being used for NGS has some of the primers and the fusions that are captured or commonly seen in sarcomas. There are some NGS companies that have done an excellent job in terms of identifying the most common fusions and genes that are relevant to sarcoma. So I think NGS is extremely important, both from a diagnostic perspective. So we catch a lot of mistakes based on NGS. Sometimes the diagnosis changes as much as 10 to 20%. It's prognostic, and it also has implications in therapies.
So what do you suggest specifically in terms of the type? Is it really the issue of mRNA and as well as DNA, or how do you figure out whether or not it's correct?
I think it needs to cover the fusions, and not just the NTRK and the ALK and the RET. There's other obscure things that are commonly not seen in the epithelial cancer world. That we do see in sarcomas, and that makes a big difference. And not all NGS platform companies bait for these genes. So it's there's I won't mention the names, but there's a handful of them that are very good. And increasingly, there's also some role for RNA sequencing upfront. But it remains to be seen how that will ultimately get played out. It's looking intriguing.
So we're going to move on now and talk about desmoid tumor and TGCT. And actually, the first time I met Mrinal a couple of years ago, we did a program on desmoid. We'd never done a program before on desmoid, and they had me scheduled for an hour and 45 minutes. I'm like, what are we going to talk about? And when we got to the 1 hour and 45 minutes, we were still going. So it's what an incredible story this is. And, also, I think a lesson here in terms of uncommon cancers and how phase 3 trials can get done. But Mrinal, let's hear about desmoid and TGCT.
No, thanks for having me here. No, I think, a lot of these successes that we've seen in these sarcomas in general is really a lot of, partnerships between academia, industry, and patient advocacy groups. I think patient advocacy groups have really been fantastic in this space. And they're really the true champions that bring together people from, in different silos together. So, they've made a massive impact in our field, and we're very grateful for all of them. So today, in the next 10 minutes, I'll talk about desmoid tumors and TGCT. In desmoid tumors, I'll primarily focus on a phase 3 clinical trial that led to a new FDA approval of a drug, nirogacestat, in November of 2023. And then we will shift focus to TGCT. This is tenovial giant cell tumor. And really about 3 major drugs. 2 of them are FDA approved, and a third one we just heard about it in ASCO, phase 3 that was concluded. And then I'll go over the clinical trials as well as the side effects and in what context to use which drug. Okay. So having said that, I think one thing to understand is that desmoid tumors, they have generally just 2 mutations. It's either a mutation in beta-catenin or it's a mutation in APC. The vast majority of these desmoid tumors have mutations beta-catenin, and these are called sporadic desmoid tumors. About 10% of them will have mutations in APC. And this is serious because these patients are the ones who can end up with FAP. So they will require... If you're thinking of desmoid, you really need to stop at very early on and say, does this patient need a colonoscopy? Does this patient need a germline testing? And again, here, if the tissue shows that it's a beta-catenin mutation, then it's reassuring that it's not an APC mutation, that they don't have FAP. But I really think it's very important to think about that early. Make sure you don't miss a patient with FAP who may be presenting with a desmoid tumor. What you're looking at here is really the Wnt signaling pathway. So whether you have a mutation in beta-catenin or you have a loss in APC, the Wnt signaling pathway really gets activated along with the Notch. The Notch and the Wnt signaling pathways are really upregulated in these tumors. So the key thing here, I would say, in terms of desmoid tumors is you have to have a little bit of a curb your enthusiasm, because when you see them, it does not necessarily mean you immediately need to react and start doing things. There's a lot of good data to suggest that it's safe to observe with scans and only treat when it's necessary. One thing that has had a big change in desmoid tumors is that we really should not be operating on these tumors, and whenever possible, we should think about, is this something that can be safely observed? When is it that we think about active treatment? There's really three major reasons. One is pain, or if the patient's symptomatic, or there is a loss of function. That's a good reason to treat. Second thing is the tumor progressing, so you can have an initial course of observation and then the tumor can progress, and that's a place to start. And of course, cosmesis itself. So these are three criteria for treatment of these tumors. There are many different tyrosine kinase inhibitors that we use here. We also use cytotoxic drugs such as liposomal doxorubicin. But from tyrosine kinase inhibitors, as you can see here, there are many drugs that are active, but the drug that has underwent a phase 3 clinical trial was sorafenib. We see excellent outcomes with sorafenib with this drug. And there's also other, imatinib has also been extensively evaluated, and something similar to sorafenib is also pazopanib. Many of these have good data. But in my own practice, I use a lot of sorafenib, and generally, globally, also people are using quite a bit of sorafenib when it comes to the TKIs. I'll focus on nirogacestat. So this is a gamma secretase inhibition. This is the really first in class. This drug does not really approved in any other indications. The interesting backstory is that a lot of these gamma secretase inhibition was initially evaluated for Alzheimer's disease. They play a wide range of roles from neurons to fibroblasts, and the gamma secretase enzyme itself is present throughout all cells, and they all play very different functions depending on the cellular context. But here in the context of desmoid tumors, it is thought that the gamma secretase enzyme activates the Notch signaling pathway. We talked about that briefly with the beta-catenin. And the gamma secretase inhibitors disrupt that signaling and subsequently cause tumor death in desmoid tumors. So nirogacestat is a gamma secretase inhibitor, and this has been evaluated for the last 7 to 8 years or even longer. And the definitive phase 3 study that led to the drug approval is called the DeFi study, and here patients were randomized in a 1:1 ratio to nirogacestat at 150 milligrams BID versus placebo, and patients were crossed over at the time of progression if they happened to be on the placebo arm. The primary endpoint was PFS, and there were secondary endpoints of response rates, patient-reported outcomes, and such. So the nirogacestat showed that it significantly reduced the risk of disease of progression-free survival. As you can see here, the curves really separate out. It's highly significant with a hazard ratio of 0.29. So very impressive results. But what's also important is that we saw this PFS benefit across many of the pre-specified subgroups. Sometimes people say, does it matter if you had prior surgery or radiation or prior TKIs? And the answer seen from here at least is that it does not matter, that this drug works really well, whether you're using in the first-line setting or in the third-line setting. Importantly, there's always been a question of, does this drug work just as well in the FAP or APC mutations? And yes, it does. And secondly, also in terms of tumor locations, nirogacestat works very well in many, many different contexts in all of this that have been pre-specified subgroups. And this is the tumor reductions. As you can see, very nice response rates with nirogacestat with placebo. And you may be looking at the placebo arm, and I think, Neil, you asked me many years ago, how come there were responses in placebo? And that's how these desmoid tumors work. Sometimes we do see these spontaneous regressions, and that's the rationale behind seeing, putting these patients on observation in the beginning. What's also important about nirogacestat is not only does it improve PFS, it also improves pain, and we see that here. And then using other functional modalities and instruments, we again see that this also improves other functions that's impacting desmoid tumor patients. The safety profile is excellent. This is a very well-tolerated drug, as I said, 150 milligrams BID. But one of the safety issues that did come up and definitely warrants a conversation is ovarian dysfunction. But what's reassuring in this study that we saw is that many of the patients who discontinued nirogacestat, they had a complete recovery of their ovarian function, and some of them had recovery even while they were on the drug. So that's but we certainly have a conversation with all patients of childbearing potential ahead of time. Next, I'll jump into tenosynovial giant cell tumor. This is also known as PVNS. And as you can see here, these are tumors that are primarily in the synovial space, involving really any of the joints and such. But what's interesting from a tumor biology perspective is that these tumors are formed by two different genes coming together. And in this translocation, they end up overexpressing CSF1 or stem cell factor 1 overexpression. So it's really the tumors are secreting CSF1, and all the different macrophages and inflammatory cells flock towards it and form the bulk of the tumor itself. So we've had excellent drug development in this disease, and has really been a massive success story. The very first one was the Enliven study with a drug called pexidartinib. It's a highly potent inhibitor of CSF1R. In this phase 3 study, it was again randomized to placebo versus drug for up to 25 weeks, at which point the endpoints were evaluated. And what you can see here again is pexidartinib has excellent response rates, rapid responses. These are durable responses with this drug. And even when patients who are on placebo subsequently crossed over, they also had excellent responses. The drug has some serious adverse events. I think as you can see here on this screen, there are some hair color changes. But the major issue is really the ALT, AST, and the ALK-Phos issues with this drug. In fact, there were some deaths and liver transplant issues that happened with this drug that subsequently resulted in a REMS program with pexidartinib. So we are all very careful when patients are enrolled in pexidartinib. So the next generation, or the most recently approved drug, is this drug vimseltinib. This is another tyrosine kinase inhibitor, but with a slightly different mechanism of action. And what we see is the second study, phase 3 study, known as the MOTION study, very, very similar design to the previous one that I mentioned. It's placebo controlled study. And interesting thing about this study is that the drug is only given twice a week. It's also an oral pill as well. And again, what we see in the phase 3 is that we see very robust responses. These are durable responses, as you can see here in this waterfall plot. The other thing, just as the previous drugs, these tumors not only have resist response, but they also have very nice tumor volume reduction. And accompanying all these tumor reductions and volume reductions is also improvement in patient-reported outcomes, such as improvement in range of motion as well as pain, which are major barriers for quality of life for these patients. And as you can see here, these patient-reported outcomes with vimseltinib, which is now FDA approved, again shows an improvement in range of motion and physical function, and an overall improvement in their health status as well. Again, in terms of side effects, very well tolerated. But importantly, in this study, they did not see the issues that were previously seen with pexidartinib with the liver dysfunction. So this does not have a REMS program, so that does help us as well as the patients quite a bit. So as we say here, there's no evidence of cholestatic hepatotoxicity that was previously reported with pexidartinib. So that's certainly an improvement over the first generation of approved drugs. And this is fresh from ASCO 2025. This is the Maneuver study. This is also a phase 3 randomized double-blind placebo-controlled study of a drug called pimicotinib. This is a drug that is taken daily. And patients who received this drug also had an excellent response in tumor size, as you can see in this waterfall plot, and also an improvement in the tumor volume, improvement in patient-reported outcomes, both in terms of pain, stiffness, as well as range of motion of their joint. And similar to these other drugs, also very well tolerated oral molecule for this class of agents. So just to sort of quickly summarize in my last slide is if you look at the phase 3 published results, the pexidartinib, as I mentioned before, is approved, has an overall response rate, as mentioned here, and then vimseltinib just recently approved about 6 months ago. And this drug also essentially shows very nice improvements. And the Maneuver shows a 54% response rate with pimicotinib. So all these, so now we have an abundance of drugs in this space, which are all very active, excellent response rates, durable response rates, and improvement in patient-reported outcomes. Again, when it comes to toxicities, the only thing I would say is that some of these can increase CPK. So you just have to rule out that there's no rhabdo or MI. But most of the time, these are asymptomatic elevations in blood tests and not of great concern. And then you can see rash, pruritus, as well as lipase increase. These are all worth thinking about. So finally, in terms of the management of tenosynovial giant cell tumors, I think we can, this was recently presented by Dr. Pennell at ASCO. If it's asymptomatic disease, it's okay to have an active surveillance. If it's symptomatic, certainly use NSAIDs and other opioids, and definitely think about targeted therapies, the ones that I've mentioned here. Primarily, the only 2 FDA-approved ones are pexidartinib as well as vimseltinib. Pimicotinib is not approved. It was just presented just now. So we'll stop with that.
So I want to get into some of the questions we got from the oncologists. Also, we have a case in the chat room I'd like to run by you. But Rashmi, you had this really interesting paper in Cancer on the ovarian toxicity that's seen with nirogacestat. Can you talk a little bit more about that? Actually, the case here is a woman, but she's 56, so I guess that's not going to be an issue. But sort of what the pathophysiology of why you see this, typically what happens, and also the connection in general between desmoid and hormones in terms of the incidence, what happens during pregnancy. Is it just about hormones or the cytokines of pregnancy? Any comments?
Wow, that's a big question right there. but yeah, there's definitely a hormonal connection that we see. We do see desmoid tumors arise in the setting of pregnancy. We have historically used tamoxifen as an agent in management of desmoid tumors, but it's really unclear if it's how efficacious it is now that we know more about spontaneous regressions. But I will say that I've used tamoxifen over the years, and I kind of think it works, although it's difficult to prove in some situations. So then we know the GSI class of agents do have a kind of a class effect in terms of affecting what we think are primordial follicle exhaustion, where they can kind of induce this, almost temporary menopause type state where patients have hot flashes and, become amenorrheic. That doesn't happen in every patient that's of childbearing potential. However, we definitely have seen changes in a lot of the hormonal numbers that have been added onto some of our studies. So what do we do with all this information? Essentially, we always have to counsel our patients. We believe that the effect is probably temporary because the majority of patients do regain their ovarian function while they're receiving drug, but there's never any guarantees. So I always tell my patients that, there's definitely some hormonal effects. We think they're temporary, but we're not sure. If it's really important to you to have children, you could consider fertility preservation before starting these agents.
And Mrinal, actually, in the chat room, Chu says, quote, in the past, we used tamoxifen to treat desmoid tumors. I also encountered 2 patients who developed desmoid after ovum retrieval, indicating the possible role of hormones in the disease. Is there any role of ovarian dysfunction in the efficacy of nirogacestat? Chu also brings up.
I didn't follow your second question about ovarian dysfunction.
Whether or not the ovarian dysfunction is contributing to the anti-tumor effect.
I don't think so. I don't fully buy into the connection with estrogen. I'm not sure the connection is estrogen, but it may be the state of pregnancy, which, as you know, releases thousands of different cytokines. And my sense is, and there's some of the emerging data showing that some of these cytokines of pregnancy, primarily PDGF, platelet-derived growth factor, as well as VEGF, which are all massively secreted during pregnancy, may be playing a role. And I think the responses that we're seeing with tamoxifen may be simply that these tumors are regressing spontaneously after pregnancy. And I think of all the ones that do respond and have an excellent outcomes are typically the pregnancy-associated desmoid tumors, which usually occur in the abdominal wall. I think those patients have one of the best outcomes. So I'm not sure we can prove that tamoxifen is really doing anything there, or whether it's just observation alone could have got you to that place. So it's a little bit controversial on the role of estrogen receptor itself in this disease. One thing I want to, on your slide, I do want to. Someone brought up the issue of radiation. Radiation is something that we do not use in this disease at all, and we should go above and beyond not to use it, and only use it if all other avenues have been exhausted. I'll say this because these are young people, and we've seen a decent number of patients with desmoid tumors who've been radiated, and of course their desmoid tumor is controlled, but they could end up with a secondary high-grade sarcoma related to radiation, and that can be fatal. So I would say do not use radiation in this setting.
So, Rashmi, one of my most common questions is how do you decide when to initiate therapy in these patients? I thought it was interesting that in the earlier sorafenib study, you saw a bunch of responses in the placebo group, but then in the DeFi study, even though you saw a response in placebo, there were less, which made me think that maybe we were getting better at selecting patients who need to be treated. How do you decide? Is it mainly symptoms? Is it the size, location? How do you decide whether to initiate systemic treatment?
For sure, that's a great question, and one that Mrinal covered a little bit, but really, one thing I wanted to point out is, the selection criteria of a study is always very important. So, the sorafenib study required a 10% increase in unilateral tumor dimension, while the nirogacestat study required 20% increase, and that may be why more patients had spontaneous regression in the sorafenib study, because perhaps they hadn't been growing as quickly and at a rate that warranted treatment. So, for this patient population, a lot depends on symptoms. The nirogacestat is technically indicated for progressing desmoid tumors. That's not specifically outlined in the FDA approval, but typically, if patients are having symptoms paired with growth, is typically an indication for treatment. Or if the tumor is in a life-threatening area, particularly some of the abdominal tumors, where if they're going to progress, they can cause bowel obstruction, is when we consider treatment.
So, Mrinal, a couple of cases. One actually in the chat room, Dr. Rudolph. I'm just going to read what she says. 56-year-old woman with periscapular desmoid has been on nirogacestat for 3 months. She has severe fatigue from the medicine, also listed in the package insert. Have you seen this? How do you avert it? Would dose reduction help? The patient wants to stay on the same dose if possible. Also, the patient, I guess, has a discomfort after 3 months, not much change. How long does it take before you see response in terms of pain?
All great questions. I think, look, the treatment of desmoid tumors, whether it's cytotoxic, TKI, or GSI, this can take time. To get maximum response, we don't see this for months at a time, we usually see best response after a year and so of treatment. But having said that, I don't think it's appropriate for patients to suffer with drug-related side effects for such a long time. It's just not a way to live. So I think in that context, if a patient's having severe fatigue, that's not something that we usually see with GSI. These drugs are very well tolerated. So if a patient is having severe fatigue, I would say a couple of things. One, make sure that there is no drug-drug interaction with some other drug that this patient's on to make sure that's not contributing. But otherwise, I think it's perfectly safe to lower the dose of the drug. So I know the FDA-approved dose is 150 milligrams twice daily, but it's perfectly safe to decrease it to 100 milligrams twice daily as well. And even on the DeFi phase 3 study, many, many patients had a dose reduction, and they did quite well. You had a couple of other questions related to that scapular patient?
Well, you answered, I think, most of them in terms of dose reduction and the fatigue. Actually, we have another case that was submitted as part of the survey, Rashmi. 19-year-old woman with symptomatic pelvic desmoid for 5 years, relatively stable on low-dose sorafenib, but now off, but now it's getting bigger and more pain. What do you recommend next? If you do give nirogacestat, what do you advise in terms of ovarian function? What about upfront egg harvesting?
So a great case, and definitely have had similar situations with young patients that were thinking about nirogacestat, which I do think would be reasonable to try at this point. If the patient is no longer having benefit from sorafenib, oftentimes we have a nice benefit from another class of agents. I usually typically tell them the same thing we talked about with the ovarian function, that we're not certain. We think the effects are temporary, but, to be on the safe side, I always have them meet with our fertility experts. And if it's very important for them to have kind of this guarantee that there's, literally something in the bank in case there is some more permanent damage that we don't suspect, then they can have that. And then I would proceed with nirogacestat if they were interested.
What about diarrhea with nirogacestat, Rashmi? To what extent do you see that, and does dose reduction help?
Absolutely. I think, I use a lot of dose reduction in my patients and still get really nice efficacy. So one thing I always tell my patients, we never want the treatment to be worse than the disease. And even though it can be a symptomatic disease, it is a benign disease for most patients, although occasionally life-threatening. So, definitely use Imodium, sometimes have to progress to Lamodal, but often incorporate a dose reduction as well.
So, Mrinal, I don't know how many oncologists usually read cancer management and research, but I found a paper that you wrote that had an interesting title that I think reflects a lot of what you were referring to: Capturing Patient Voice to Improve Outcomes That Matter to Patients with Desmoid Tumor. I thought that the patient-reported outcomes in the DeFi study were incredible. I don't remember seeing that in oncology. So dramatic. Any comment on how patients were involved in the DeFi study, and particularly what was seen there in terms of patient-reported outcomes?
No, thank you. As Rashmi said, this is a benign disease. It's a locally aggressive disease, and it can certainly, have a huge impact on patients' quality of life. These are young people who are in school, they are in college, they're newly married, and they may be on opioids, they may be having, other issues in terms of, how to function. But the key thing is that, very rarely do people die from this cancer. And of course it can, involve the abdomen, and it can perforate, and we can have, bad outcomes. But generally, overall survival is not a good endpoint. And as you saw in the DeFi study and many of these other studies, PFS is the endpoint. If PFS is, it's usually a surrogate for overall survival. But if the disease patients are not dying, then how exactly is this the best endpoint? So I think in order to say, well, if you're going to have tumor regression, the question is, so what? Is it improving patients' quality of life? So this desmoid disease-specific patient-reported outcomes was really developed in close collaboration with the Desmoid Tumor Research Foundation, which is the largest patient advocacy group dedicated to patients living, with desmoid tumors. So working with them, this tool, this patient-reported outcomes instrument, was developed and used in the DeFi. And as you can see there, patients' improvement in pain, improvement in sleep, improvement in range of motion. So this really shows that these drugs are meaningful in this context, that it's not just an improvement in PFS, but it actually has a real-world benefit for these patients.
So a final question back to you, Rashmi. Several people in the chat room are asking about choice of CSF1R inhibitors. Here, vimseltinib and pexidartinib, but now we have pimicotinib. Which one are you using? Or which one do you think has the greatest advantage, Rashmi?
Well, pimicotinib is not available just yet, so that makes that easy. And so we're not able to access that at this point. Vimseltinib, definitely has some advantages in terms of dosing just twice a week as opposed to twice daily, and the toxicity profile without the cholestatic liver injury, not requiring the monitoring. Vimseltinib has been kind of my new standard of initiation. Although I have plenty of patients on pexidartinib that are doing well that continue on it.
So, Rashmi and Mrinal, thank you so much for bringing us up to date on this important topic. Audience, thank you for joining us. Have a great day. Thanks so much, Mrinal. Thank you,
Neil. Thanks for having us.